So I'm just doing it. Am I audible, ma'am?
Yes, you are.
A very good evening to our esteemed speaker, chairperson, and colleague, and everyone present here. I, Garima Singh, clinical psychologist, Balrampur Hospital, Lucknow, extend a warm welcome to all of you on behalf of
Yes, you are.
very good evening to our esteemed. Am I audible now?
Yeah, you audible.
Actually, there was a technical glitch.
Hmm.
So, I, Garima Singh, clinical psychologist, Balrampur Hospital, Lucknow, extend a warm welcome to all of you on behalf of Team IMHRC to the fourth lecture in the Enlightenment series titled Reflections. This initiative has been taken by Indian Mental Health and Research Center, Lucknow. Reflection is a series of masterclass in mental health. The lecture series aims to unite mental health experts and intellectuals, fostering an environment that encourages discussion and explore the multifaceted nature of mental health related issues. So, the topic of today's discussion is family intervention, theory versus skill, what really matters. Our esteemed members for today's session are Dr. Vasudha Singh as a speaker and Dr. Shazia Siddiqui as a chairperson. I would like to take this opportunity to introduce our esteemed speaker and chairperson. Our speaker, Dr. Vasudha Singh, is a RCI licensed clinical psychologist with a vast experience in the field of mental health. She has completed her graduation in psychology and master's in clinical psychology from RGPG College. She has completed diploma in clinical psychology from St. John College, Agra, and was awarded a gold medal. She has completed her MPhil in clinical psychology from IMHAS, New Delhi, and PhD in psychology from AIM, New Delhi. She has started her private practice and named her clinic as Vikalp Psychotherapy Clinic, which is located in Merit, Delhi, NCR. Her vast experience started with the setup of neuropsychology clinic way back in 1996 with a few like-minded students of psychology, and she worked in various schools of merit to spread awareness related to mental health. Moreover, she worked as a counselor at Child Guidance Clinic. She also worked as a consultant clinical psychologist at Merit Institute of Neurosciences. She also worked as a senior clinical psychologist at Department of Psychiatry, Subharti Medical College, Merit, and Muzaffarnagar Medical College. She has expertise in teaching, training, supervision, and research. She specializes in family therapy, individual and group therapy for substance dependence and anxiety disorder, and also in the administration of the Rorschach test. She has delivered presentation at national and international conferences and received awards for her outstanding papers. Moreover, she was nominated member of Central Mental Health Authority, Ministry of Mental Health and Family Welfare, Government of India from 2019 to 2021. With this, we welcome you, ma'am. Further, I would also like to take this opportunity to introduce our chairperson, Dr. Shazia Siddiqui ma'am. She is also an esteemed clinical psychologist and a leading expert in the field of clinical psychology and behavioral sciences. She serves as a consultant psychotherapist at Healthy Mind Neuropsychiatry and Behavioral Science Center in Lucknow, India. She has trained in clinical psychology at Central Institute of Psychiatry, Ranchi. Her impressive background include her tenure as an assistant professor of clinical psychology and head of department at Central Institute of Psychiatry. Additionally, she holds the prestigious position of visiting faculty at Amity University, Lucknow. She is an active member of Rehabilitation Council of India, Indian Association of Clinical Psychology, Indian Psychiatric Society, and several other professional organizations. She is also part of the organizing team, the weekly Thursday Music webinar. With this, we welcome you, ma'am, and thank you so much for taking out your valuable time for this today's discussion. Over to you, Shazia, ma'am.
Thank you, lecture, and welcome to all the participants and the chairperson and our very esteemed speaker. It was very impressive to hear your vast accolades, ma'am. And I think family therapy is a very essential topic because we all know what family therapy is, but we don't know how to do it. So that is the problem. So I guess we are really looking forward to hear from you as to how exactly it is done and what are the complications, in fact, what are the impediments that we, because as of now, whenever you see patients with family therapy, what one thing happens, they don't know how to disagree constructively. So that is one skill I think which we need to teach uh, the people who come to you as a family how to disagree constructively, because if the skill is not there, then you either persuade or you try to prove yourself right, and that the other person becomes like a fortress. You can't enter it. And that one skill is very important. And I'm really looking forward to your lecture. Thank you, ma'am. Thank you. Go ahead.
Am I audible and the screen visible?
Yes, ma'am, you are audible and your screen is visible.
Thank you so much for the confirmation. Good evening to all who have joined for today's lecture series of reflection. At the outset, I would like to thank the organizers to give me this opportunity to speak up my mind in front of this august audience. Thank you for the kind introduction. Without further ado, I, Vasudha Singh, would like to start with today's lecture on family intervention theory versus skills, what really matters. To start with the overview of presentation, it will follow, we are going to start with the introduction to family intervention and its overview. Moving on to next to the brief understanding of theories which focus on behavioral patterns, belief systems, and contexts of children and adolescents and their families. We will then move on to some latest research evidence of family therapy in substance use disorder to understand that it is still a contemporary topic in mental health issues. Further, we will understand what actually makes a difference in therapy. Talking about the different set of basic skills required for family therapy, and talking about the contract of therapy, and moving on to the paradigm shift from individual to family therapy, and also calculating the cost and benefit ratio of family intervention in general. So, what are family interventions? Family interventions is an umbrella term which is used by the mental health professional for understanding various mental health issues of individual in the context of family. It entails planning, treatment, engagement in of the family members in the treatment regime. Family intervention gives the member insight into the symptoms. Be prepared for any of the acute episodes. It also helps the family members to cope with the chronic mental health issues and lessen the burden to some extent. Now, why the families are to be involved in the treatment? not only because they are financially and emotionally a support to the person who is having a mental health issue, but also that our country, along with other South Asian countries, are from collectivistic orientation. That is, the society who have a family orientation. So families of individual with psychiatric illnesses have communication problems like expressed emotions, caregiver burden, decreased quality of life, and which add on to relapses and affect the outcome variable of many mental health illnesses. Now, what is delivered in family intervention depends upon the stage of the illness, the nature of the psychiatric symptoms which the individual is having, the crisis, the current crisis, and the disability caused by the illness. Moving on to an overview of family intervention. Family intervention, it assesses the functions and roles of the families. It also assesses how have the family been affected the patient, and patient has affected the family. The problem of concern is identified, and the assessment of coping and burden perception is made. It is followed by the treatment engagement and psychoeducation of the illness on the biopsychosocial model. Now, basic intervention is delivered, which can be brief intervention, long-term intervention, family in the form of family therapy, as per the problem defined. Special attention here should be paid to the communication patterns and the emotional exchange which is happening between the patient of any psychiatric illnesses and the family as such, or the whole family milieu. Moving on to the theories which focus on behavioral patterns, we would like to start on the brief family therapy approach, which was proposed by Mental Research Institute, also called MRI Brief Family Therapy. It focus on the patterns in context of child and adolescence. We are talking about in context of child and adolescents and their families. These theories focus on tracking the repetitive behavior pattern involving problems and ineffective solutions. Treatment includes disruption of problem maintaining behavior pattern, especially targeting problem maintaining interactional patterns. Now, paradoxical or counterintuitive method is one-stop solution for these type of problems. That is, the therapist stance is to dictate step by step, restrain, and such instructions are instrumental in change. Moving on to the other strategic family therapy, it centers underline the theme of the families are ambivalent about the change. That is, usually family problem entails some sort of interpersonal functions. When under strategic family therapy, when we talk about healthy families, they are such families which have very clear intergenerational hierarchies. They move from one cycle to another cycle very smoothly. But in the problematic family, they lack such families and the family members, they lack family flexibility. Now, such treatment brings about a change in the pattern of interaction, and they reframe the problems. This change happened between the session. For example, the hierarchical incongruity are handed over to the father by making a change and giving rest to mother. Or a bulimic child is left to mix the food and is asked to flush in front of the parent, etc. Moving on to the structural family therapy, which is very uh, talk of the town. The central idea of structural family therapy is problematic family organizational structure may compromise the capacity to meet the demand of life cycle changes. And these life cycle changes can be very unpredictable, interfamilial, or extrafamilial stresses. Now, in such structural family therapists, they join hands with family to understand the demand and facilitate problem solving attempts. They also help the family to use their own latent resources to modify the structure and the boundaries. Such in such family therapy, the unhealthy families have a rigid boundaries and enmeshed relationship with the patients, and the family member avoid conflict by cutting the conversation and abuse the parental powers without taking account of the child need. It is said a dysfunctional family, according to structural family therapist, is one that cannot fulfill its function of nurturing the growth of its member. Moving on to a more mostly used cognitive behavior, marital and family therapies. The central assumption of CBT family therapy is problematic behavior and cognitions are learned and maintained by a particular type of repetitive patterns of interactions. Now, CBT therapists help to disrupt problem maintaining interaction patterns by coaching skill required to shape and reinforce the non problematic behavior in other family member by challenging their negative cognitions. As the negative schema dominate the thought process of the family members. This can be done by strategies like contingency contracting, communication skill training, cognitive restructuring, etc. Now, moving on to the theories which focus on the belief system. Uh, First is positivism. Perception are true reflection of the world as it is. When the family has a dispute, the therapist help to show the real position by behavioral and psycho educational approaches. Moving on to the other, constructivism. Constructive therapist argues that individuals construct their own representation of the world. They are represented by the sense organs, nervous system, information processing, and belief system. The therapists here make the family member see the problem in a unique way. They change the problem situation from less useful to more useful way, which ultimately lead to the problem problem solution. So the sequence is either repunctuated, reframed, or relabeled. Moving on to the narrative therapy. Therapy central goal is to help people reauthor their lives and redefine themselves in a non-pathological way. Within the narrative frame, individual family member have open space for authoring alternative stories and get rid of oppressive narrative which maintain the problem. Thus, it brings back the personal perspective. Moving on to more transgenerational and psychoanalytical family therapy. Transgenerational family therapy has an assumption that client relationship and events have occurred in the family of origin and they have continued to the current life. Members of unhealthy family are not able to differentiate from the family of origin, and children and parent becomes emotionally cut off. They repeat the same parental problem by legacy of invincible loyalties. In the psychoanalytical family therapy, the healthy family accept members as it is with its strength and weaknesses. But for unhealthy family, it's all good or all bad. It it is a very tedious and long-term therapy which requires more than 100 sessions over 2 years time period, and it is actually used in marital discord and bereavement problems. Uh, Moving on to attachment-based therapies. Uh, in attachment-based therapies, the unhealthy families have rigid interactional pattern that block the emotional engagement. They don't provide new scripts, therefore, the old scripts are repeated. Therapists facilitate mutual expression and acceptance of attachment, needs, and related emotions. These are used in marital discord and child emotional behavior patterns. Moving on to multi-systematic approach. In this, the unhealthy family is poorly adjusted with individual members. They have weak parental subsystem, anti-social peer relationship, and little community support. The intervention is at individual level, peer and school-based level, and aim is to disrupt problem maintaining behavior. And such approaches are used for delinquency, drug abuse, and child abuse, in which the family is a very important part. Moving on to psychoeducational approaches, it is mainly used by unhealthy families. Unhealthy families have emotionally charged or critical or over involved relationship with their ill members. It in turns increases the relapse and poor illness management. Work is done by therapists to improve the communication, problem solving skills, and coping strategies. For example, such psychoeducational approaches are used in schizophrenia, bipolar disorder, and chronic illnesses. Moving on to various Moving on to research evidences of family therapy in substance use disorder. The experiences family relationship are important in drug treatments since they support patient compliance and engagement. It was also found that behavioral couple therapy has better cost benefit ratio than individual treatment. It has greater abstinent and stronger relationship and decreased divorce and domestic violence rates. According to another recent study, there was absence in understanding, disagreement, rejection, and non-acceptance by parents in the family of the patient study. Moving on to further research in methadone maintenance treatment, in which multi-family therapy was used with a reflective team and their outcome were measured. Clients and their selected family members attended 10 to 2 hour long intervention held twice a week for 10 weeks. Together with the group treatment paradigm, family members were able to share their experience and grow their ability to communicate. In another study, family members who have a history of antagonist interaction, and in an Indian study, mental health professionals need to consider coping and expressed emotions in treatment plan while dealing with substance dependence. In another meta-analysis, research found out that significant others in treatment has a considerable benefit others compared to other treatments for SUD, and systematic family therapy is well established as a standalone treatment. Behavioral couple therapy has also shown overall efficacy and effectiveness and cost benefit and hypothesized treatment mechanism for substance use problems, couple relationship, functioning, and intimate partner violence. Now, going through these theoretical background of researchers, what actually makes a difference in treatment when we are talking about family interventions or family therapy, any type of family therapy. According to Miller, 1997, there are client factors, therapy relationship, hope and expectancy, and therapy models, which are the factors. And according to the percentage, 40% attribute to the client factors, which is the existing strength and competencies of the client, and past and partial solution which they have made for the problem which they have come up with. Now, the therapy relationship is very important, which contribute to 30% of change, which is matching the client motivation, letting the client set goal, and empathy, respect, and being genuine. Moving on to hope and expectancy amounts to 15% of change, which is separating the problem from the person, highlighting the competencies, and therapists believe in the change. And the therapy model, which we have discussed so far, and the others, they contribute to 15%, and they can be any different tools for different client as per their needs. Now, there are the three types of basic skills which are needed for family therapy. One are conceptual skills, perceptual skills, and executive skills. Conceptual skills are skills which are taught. In way back in the 70s, McMaster semi-programmed some text theoretical concepts which were taught as per the family therapy. And time and again, the knowledge was tested at various levels. So these are the conceptual skills which an individual during the training or during the learning they develop regarding the family therapy. Perceptual skills are the skills which are inculcated in an individual, in a therapist by seeing various videotapes of family therapy, certain role plays, or seeing different family therapy or conflict scenarios. Now, executive skills are skills which an individual can get only after he or she has worked with the families. They may have worked with the simulated families or under supervision. And it is always better that the live or live supervision is being given to students from by the supervisors from one-sided glass, so that they may tell that where there and then what they have done wrong while dealing with the patient. Other skills for the family therapy can be learned by another method of consultation. Now, consultation has no hierarchical distinction between the therapist and the consultant, which is giving the consultation, and it can be purely advisory. Now, live consultation are very useful when they are useful when there is a conflict between the therapist and the patient. When the therapist is being regulated by the family somehow, the therapist is being drifted from the task of family therapy, and there are some eureka move by the consultant in which the consultant knows where the the therapist is going to what decision is the therapist is going to take now, and he can predict it, and he can just guide the therapist what to do according to the situation. And also the consultation also helps when there is a misreading by the therapist of the problem of the family which is in conflict. Moving to other basic skills of family therapy is the power dynamics in the family therapy. It is very important to understand the family dynamics in the family therapy, the emotional intensity of the family. Then it requires a lot of skill to join the family. It by Whitaker, it was once said that family therapy is like a surgery and therapist is like a anesthetist. So the family therapist has to join with the families in conflict and have to establish a leadership role, because because he has to steer the process of family therapy. And what in the due course of time is very important is the balancing of interaction between the one or two family members or more than two family members which are participating in the family therapy. It is also very important to moderate the intensity of the family therapy, and also at some point of time lowering the intensity not only by verbal cues but by lowering the voice of the therapist also can lower the intensity of the whole family therapy process. Moving on to the REM approach to work with conflict, given in 2000. REM stand for reframe the angry position, provide a positive interpretation of each partner's position. E is to empathize each partner position, model empathy, encourage partners to empathize with each other, and M is to establish mutual goal, also to set small, mutually agreeable goals to build cooperation. Contract of therapy is very important. A clear therapy contract is a bedrock of successful treatment. It consists of two elements. One is what the family want from the therapy, and second, what the therapist develop for the family. So the therapist develop a vision for the future, make the goals measurable, and resolve the conflicting goal. Moving on to the paradigm shift from individual to family. Now, how many of us, when we see patients, we think about the family? We see a patient as an individual most of the time and less in the family context due to many reasons. But recently, there has been a paradigm shift from individual to family. One is because evidence-based couple therapy has been proved very efficacious, and superiority of couple and family-based therapists has inculcated a paradigm shift in recent years. But this shift is a tip of the iceberg, because still so less is done done in an individual form and group therapy quarters. So talking about family is a far-fetched idea. Now, such talks shows how much less importance or interest student shows to such type of topic. Moving on to the cost and benefit ratio or calculations, the shift needs a evaluation of cost and benefit. Family therapy is taxing, supervision is required, and to be trained lead needs lot of endurance. Now, carrying out in a low medium income group is challenging. Change in family milieu for better outcomes is very difficult due to dropouts, because family therapy needs lot of long-term family therapy needs lot of sessions, which is very taxing monetarily also. Family involvement in the treatment regime requires lot of manpower. So one therapist for a individual therapy, one or two therapists for family therapy, which is a very far-fetched idea in our scenarios. So the making policy makers understand the benefit and understand the difficulty which is being faced due to lack of including family members in the treatment regime. Yes, it is a Herculean task, and to change the perspective from individual to family. But we can always take home a family perspective. Thank you.
Now I would request the participants to post their questions in the chat box. I would request Shazia ma'am for the concluding remarks.
Thank you. Thank you Oscar, for enlightening presentation. And you said the family therapy can be challenging at times. They're coming to you with a lot of hope. So when they consult at any therapist, family therapy, the point is that they would all want to put their viewpoints. And at that point of putting their viewpoints, a lot of emotions fly high. As a therapist, a very important skill as a therapist that you need to learn is to set boundaries. You have to make the clients understand that beyond this point, you have to stop. And empathy is important. Empathy, as in when somebody is expressing something, the need behind it, because a husband, wife, children, or couple, or whosoever is coming for family therapy, they've all been angry, enraged, and they have a problem. The whole system is collapsing. So the whole idea is how to keep the system intact, how to interact with each and every client, the children or the family or the husband or the wife, without siding with anybody, any one of them. And I think that's the challenge. Like I initially also said, constructive disagreement is a skill which we need to teach the family members, which usually incorporates active listening, not putting the point forward all the time. Is the relationship is important. That relationship, you might feel ignored at times, feel that you're not being heard. But that's where they're coming. That's where they're coming. You need to understand the emotions of the family, and then go accordingly, rather than siding with each with one individual person. Thank you. Thank you, Vasudha ma'am.
Thank you.
Thank you, Shazia ma'am. We have one question. Do you take family member individually or always together? Is the question asked by Sonal. Go to you now.
Yeah, so it depends upon the availability of the family members. At times, it is very difficult that all the family members are available for family therapy. Mostly in the first session, the parents they come if the child if the index patient is a child or the parents they come. But due to repetitive sessions, it is usually one parent or or one or two family members which are coming. Unless and until there is the psychopathology is in the whole family dynamics is disturbed, then then they are being instructed to bring to come up with the whole family. But the feasibility, due to feasibility issues, it is always seen that it's not always all the family members come for the family session. So it depends upon the need also. There are various feasibility issue also which are seen, and also if it is required that the whole family should come, so the whole family has to come for the sessions.
So to add on to what Vasudha ma'am is saying, a lot of times you will not get the case of family therapy as such. So a child would come, and because whenever any problem happens, the weakest link of the family collapses, and that is the child. So their family will come to you with the problem, portraying as if it is only the children that are responsible, or the child is in the entire family. So when you suggest family therapy to them, it might be very threatening at times, because people will say, I don't have a problem and my child has a problem. So you have to insist that the roots have to be taken care of if you want the flower to blossom. Child is the blossom, and in that process, so it's very important to explain to the client what family therapy is all about, because a lot of times people think that, or think that, I don't have a problem, and only my wife or my husband or my XYZ has a problem, so please deal with them. So to empathetically understand that when somebody's referring them to you, or somebody's saying that you also might have a problem, could be threatening at times. So this could be done in individual sessions, and it could be done with family as such, so that how's my behavior impacting my partner, how's my behavior impacting my children or my family or XYZ. So like I said, you can do this in individual sessions, and you can also do this within the family. Thank you.
Yeah, thank you so much. That really kind of cleared the doubt. Thank you.
Thank you so much, ma'am, for the insightful session. We don't have further questions from the participant side. Any other question is again welcome. If anyone have any question, please post it in the chat box. I don't think we have more question. Now I would invite Dr. Geeta Singh, Organizing Secretary of Reflection, to deliver the vote of thanks to our esteemed speaker and chairperson.
Thank you, Garima. And thank you to our speaker, Dr. Vasudha Singh, for covering such a very pertinent topic. And yes, family interventions are highly relevant for multiple reasons. It helps in addressing the underlying root cause of any issue. And it is also very helpful when we consider for the long-term treatment outcome. And majorly because of its focus on the holistic approach of treatment. So, Dr. Vasudha, thank you so much. And your dedication to supporting families is truly commendable. And we are grateful for the opportunity to learn from you. Thank you once again for sharing your knowledge and expertise with us. I further thank our chairperson, Dr. Shazia, for your contribution as the chairperson.
Thank you.
Your presence and inputs made a huge difference and contributed to the overall success of the event. And it was a pleasure to have you to chair the sessions for reflection. So thank you so much,
Thank you.
ma'am. And last but not the least, thanks to the moderator, Ms. Garima Singh, and all our participants for joining with us for reflections. Though we were expecting more number of questions on the topic, but okay, whatever. So thank you so much, everybody.
Thank you so much, ma'am. Good evening. Good night, everyone. See you all in the next series of reflections.